Hey team, this is Alison Moe. Thanks for joining my GHAPP MASLD Community Network. Today we're going to be talking about specifically alcohol and the relationship with it and metabolic associated steatotic liver disease, or MASH. It's a complex relationship. It's a hard thing for us to be able to separate because of two reasons. One, we want patients to be honest about their use, but we don't want them to feel ashamed that there's a reason why they can't discuss their or quantify appropriately their alcohol use. But also, we want to make sure that we're providing patients with the appropriate treatment options based on how much of their disease may be alcohol related and how much of their disease may be secondary to metabolic associated steatotic liver disease. So just a couple of questions, and I'll start out with reading the question and then we'll go through a little bit of an explanation. How do you effectively screen for and quantify alcohol consumption in patients presenting with suspected metabolic associated steatotic liver disease, and why is the accurate assessment of that important? So I'll give a vague example of a patient that I had not too long ago. I was screening this patient for MASLD, and when I asked about alcohol use, she said to me, none, but then also happened to tell me that she was going to be going to a tequila tasting party with her daughter for her 21st birthday. So I think when you have certain conversations with patients, you can't just say, do you drink alcohol? I think the conversation needs to be, do you drink alcohol during the week? Do you just drink alcohol on weekends? When you drink alcohol during the week, do you have a glass of wine or two every night with dinner? Do you have a glass of wine or do you have a glass of wine? Do you have one cocktail or do you have one cocktail? These are things that are super important for quantification purposes for multiple reasons. Number one, because we know that continued active drinking can continue to further advance somebody's liver disease. And two, I want to make sure that as the patient is following up, that some of my lab tests at follow-up are accurate. And for that, we'll go into one of our other questions, which was, how does ongoing alcohol consumption interpret your liver function tests or non-invasive testing and put the patient as eligible for MASH pharmacotherapies? So, if someone is using alcohol enough that they may have alcoholic hepatitis, which is also a reason for elevated liver tests, we expect that those numbers do not get better unless the patient is free from alcohol for 4 weeks. So if I have a patient who I'm planning on starting a pharmacotherapy on for metabolic steatotic liver disease, and that patient is continuing to drink more alcohol than what they initially reported, then at follow-up 3 months down the road after starting therapy, I may notice that those liver function tests are not getting any better. And that would prompt me to then have a conversation with the patient to say, are you drinking? Are you drinking more than what you told me initially on our initial investigation? Did you start having more wine at night with dinner than you were having before, etc.? The other things that we talk about are, what are the practical management strategies for people diagnosed with metabolic associated steatotic hepatitis who consume alcohol above the appropriate thresholds, and how do we refer them and give them appropriate counseling techniques? So, the AASLD recommends that 20 grams of alcohol in a day for a woman and 30 grams of alcohol in a day for a man is only if somebody does not have advanced fatty liver disease. If somebody has F2 fibrosis, the AASLD guidelines say 0. So if you have a patient who just has fatty liver, but they do not have any fibrosis, technically, unless they have significant risk factors, that's listed as an acceptable amount of alcohol for consumption. I tell my patients if they have fatty liver disease and we are already working on diet and lifestyle changes and weight loss and glycemic index, alcohol is a huge source of calorie consumption. People are drinking their calories instead of eating them. So for me, if I have patients with fatty liver and we're talking about alcohol use, for me, it's 0, no matter what. And then referring people to talk to counselors or somebody who's going to be their sponsor for alcohol use is not something people should be ashamed of. It's being able to get good control of their health. This is something that is going to determine their potential life expectancy. So if they need to go to their church, or they need to go to a sponsor group, or they need to get help, or if they even need to change some of their social setting to be not to be around other people who drink, these are things that need to be part of your conversation, and it needs to be something that the patient feels comfortable with talking to you. And then, lastly, we always have the conversation with how much are patients who have alcohol-related liver disease, how much are patients who have metabolic-associated liver disease, and then how much are patients who have the MET-ALD, which is metabolic-associated and alcohol-related steatotic liver disease or advanced liver disease. And those are people who, if you really cannot differentiate, or you think that there is more alcohol use than what they're admitting to, I would check a urine PEth on those patients, because this is the urine test that only would get detected in patients who are having higher levels of alcohol use on a continuous basis. And explain to a patient that while they have combined metabolic and alcoholic liver disease, at this moment, they are not a candidate for pharmacokinetic agents if they have advanced F2 or F3 disease. But if they stop drinking and they go several months with no alcohol, then I would completely reconsider that as an option for those patients. So it's important for patients to understand that if you're already talking to them about advanced fatty liver disease, that alcohol really needs to not be part of the equation for multiple reasons: glycemic index, weight loss, giving them the opportunity to be a candidate for pharmacokinetic therapy, and improving their laboratory parameters on follow-up. I appreciate you guys and your time. Any more questions, feel free to reach out, and have a great rest of the day.